history 1 to 3 and summarized history, then went to examination. Is it the protocol in the surgery textbook, clinical surgery? Non-official. This is not going to hamper your marking.
So we usually summarize the history in short before moving to the general examination. That is why I summarized it initially.
Anyway, it's not there in the protocol, surgery textbook, right? You describe everything, then summarize, then provisional diagnosis, right?
Okay.
Forget this. Now, why did you take the history of blood transfusion in your case?
So in my case, to check if there was any previous episodes of bleeding and the patient was transfused for blood, or because blood group A is more prone to carcinoma stomach, and this is the case of carcinoma stomach, I took transfusion history. Also, if there was any past bleeding history, so if there's a bleeding history and patient has anemia and patient must have taken blood transfusion, so to rule out that, I've taken the history of blood transfusions.
In your picture, show me the picture. Okay. You have taken the consent of the patient.
Yes.
You are examining in a safe environment.
Yes.
How much exposure should be there in abdominal examination?
Sir, it should be from the zipisternum to the mid-thigh, but I have just covered the genitals for privacy.
From the zipisternum.
Yeah, zipisternum or from the nipple to the mid-thigh. While examination, I did it only for the pictures, I covered the genital areas.
You told it is moving with respiration.
Yes.
How could you know it is intra-abdominal or intraperitoneal?
So to check whether it is intra-abdominal or intraperitoneal, I can do a leg rising test.
Intra-abdominal.
So if it goes inside, if it decreases in size, then it is intra-abdominal.
It may be retroperitoneal or intraperitoneal.
To differentiate between retroperitoneal and intraperitoneal, I can do a knee elbow test.
What will happen in knee elbow?
In knee elbow test, if it is an intra-abdominal swelling, then it will protrude out, whereas if it is a retroperitoneal swelling, then it will go inside.
Right up.
Okay.
Then it may be intraperitoneal or retroperitoneal.
Yes.
The test will help you, it is intraperitoneal.
So if I do a knee elbow test to differentiate between retroperitoneal and intraperitoneal, I'll do a knee elbow test.
Anything else? It is moving with?
Respiration. The retroperitoneal will not move with respirations.
What are the structures which move with respiration?
So stomach, liver, spleen, transverse colon. All these structures will move with respiration, whereas the retroperitoneal structures, pancreas.
Which are related to diaphragm.
Yeah, all the, yeah, yes.
Yes. Huh? So it's a intraperitoneal swelling.
Yes.
And you are giving a provisional diagnosis of outlet of stomach. Where is the outlet of stomach? The location of outlet, normally. And what is the extension of your growth or lump?
So my extension is from the epigastrium to the left hypochondrium.
So, is it in the epigastrium?
Yes.
Outlet.
You're seeing the, so that will be towards the left hypochondrium. Sorry, that will be towards the right hypochondrium. The anterophilar region is towards the right hypochondrium. Yes.
In percussion,
Yes.
abdomen percussion, usually what is the description? Is it resonant or tympanic?
So it is resonant.
When we say it is resonant, usually lungs we say resonant.
Yeah, normally the abdomen is tympanic, lungs are resonant. In my case, impaired resonance is there because it is stomach, it is filled with gastric fluid mostly, so the resonance is impaired.
So it is resonant.
No, impaired resonance, sir. Stomach will normally be resonant, sir, but because of the gastric fluid filled inside, because of the
I think you
distension,
told impaired dullness. Impaired resonance.
I said impaired resonance over the mass.
That means that area is filled up by a solid lump. What do you mean by impaired resonance on in the epigastrium over the lump?
So usually we get a resonant note on percussion, but there is impaired resonance because in the gastric, like in the stomach, it is filled with content, that is fluid and gastric content. So because of this, my resonant note on percussion is being impaired. So that is what it means when I say it is impaired on.
So it is not a liver mass.
No, sir.
Why not?
Sir, I am able to insinuate my fingers in between the mass and the subcostal margin.
And the symptoms are not.
Also with the history, in my history, starting from the history, like I have findings like succussion splash, then on ausculto percussion, I get a greater curvature of the stomach at the level of umbilicus. All these points suggest toward the carcinoma stomach pathology.
The mass is tender or non-tender?
Sir, my mass is not tender.
The patient has a loss of appetite.
Yes, the
anorexia.
patient has loss of appetite, anorexia and weight loss.
Oh, so why anorexia occurs in stomach cancer?
There is non-distensibility of the stomach because due to carcinoma, the muscular layer gets infiltrated. So because of this, there will be multiple episodes of vomiting and early fullness after meals. This will result in anorexia. Sir.
Only local factors contribute to anorexia or any
No, sir.
central factor associated with it?
Sir, overall, because there will be decreased absorption, patient will be nutritionally ill, poorly built, and that is the reason. Patient will have easy fatigability and anorexia.
Usually in malignancy you have told 1.5 month.
Yes, sir.
1.5 month and here is a hugely dilated stomach
Yes.
and the lower border gast, the greater curvature is reaching the umbilicus.
Yes.
Is it possible with a benign obstruction or a malignant obstruction?
Sir, it is also possible with a benign obstruction, but this short history is not possible with benign obstruction.
Is there
This is
any
a yeah.
stomach gets dilated in a malignant obstruction within 1.5
So
months?
sir, it can take 3 to 4 months, but my patient gave a history of only 1.5 months according to her, so I have mentioned that.
Usually in a benign obstruction, dilatation is more.
Is more, yes.
Long duration,
Yes.
right? Short duration, maybe, but usually it's not a usual finding. And you have pictured these points by you. As
Yes.
per the location, the lower border is at the umbilicus,
Yes, sir.
and is a huge lump covering the left epigastrium, right?
Epigastrium and the left hip.
And it gives rise to outlet obstruction,
Yes.
non-bilious vomiting.
Non-bilious.
In which case, in benign cases or in malignant cases, huge dilation occurs?
Sir, in benign cases, sir. In case of chronic peptic ulcer diseases, huge dilatation will occur. In case of malignant,
What is the cause?
so because in case of malignancy, there can be infiltration of the muscular layer. Because of that, the distensibility of the stomach will be lost, and that is why the distension cannot be any further. In case of benign diseases, there is no infiltration, and therefore the stomach gets distended because of the obstruction.
In a chronic peptic ulcer, there may not be dilatation unless otherwise there is stenosis.
Yes.
Unless it's not that chronic peptic ulcer will give rise to dilated stomach,
Yes.
right? Now, after all this confusion, what are your differential diagnosis except carcinoma stomach?
So my differential diagnosis can be
Non-bilious vomiting.
yes, non-bilious vomiting. It can be carcinoma head of pancreas. It can be a transverse colon growth, or it can be a carcinoma of left lobe of the liver.
Carcinoma colon.
Transverse colon.
How to differentiate? It's an epigastric lump.
Yes, sir.
So how to differentiate an epigastric lump in the form of transverse colon and stomach?
Sir, in case of a transverse colon growth, so the intrinsic mobility will not be present.
Clinically,
and
how to differentiate?
Melina will be
so
there.
the gastric
lower
outlet
GI
obstruction will
bleed.
not be pronounced. There will be no ausculto, no change of note in ausculto scraping. Succussion splash will not be felt.
Don't go to succussion flash directly. Inspection finding. That's not there in your case. It's true. Carcinoma stomach, outlet obstruction, transverse colon mass, presenting with the obstruction. What will be your inspection finding? That is not there. Inspection finding. What is the direction of visible peristalsis? I told
Sorry.
it's not there in your case.
Yes, visible gastric peristalsis will be there only in carcinoma stomach. In case of
Yes.
In case of colonic obstructions, visible gastric peristalsis can be there.
Right
What
to
is the
left
difference or
will be
are the
there.
same?
No, sir. In carcinoma stomach, it will be from left to right, whereas in case of colonic, it will be from right to left.
Right to left.
Inspection. Palpation.
Sir, on palpation, I will get a hard mass. It can be mobile with respiration, but intrinsic mobility is not seen, sir.
Intrinsic mobility, what is that?
Sir, if I hold the mass and move it side to side, then the mass will not move.
This is called intrinsic mobility.
Yes.
What other differential diagnosis you told? Carcinoma carcinoma transverse colon, carcinoma stomach, and pancreas.
Because of the gastric outlet obstruction, I've put it under differential diagnosis.
Or carcinoma head of the pancreas give rise to gastric outlet obstruction.
Yeah, it can.
You think in that way. Anyway, we are now confused. How to confirm a diagnosis?
So to confirm my diagnosis, I will go with basic investigations.
Basic, what is basic?
I will start with all the basic blood investigations and upper GI endoscopy.
What pertinent finding in blood investigation?
Sir, in blood investigation, in my case, it is a carcinoma stomach, so I would first go with a complete blood count, including hemoglobin and TLC. With this, I would go with the serum electrolytes, that is serum sodium and potassium. I will go for liver function test, viral markers. I'll go for PT-INR, occult blood and stool, and also the tumor markers like CA19-9, CA125.
For diagnosis,
What is your target? She has anemia.
Yes.
She has an abdominal lump in the epigastrium. Features of outlet obstruction. What is your target in this blood investigation?
Sir,
Everything may be possible, but what is your target?
I would like to see if she has anemia, so I'll check for hemoglobin. Because there's a gastric outlet obstruction, serum electrolytes would be deranged. I would check for sodium, potassium levels.
What is the serum electrolyte dearrangement in outlet obstruction?
In case of gastric
Presenting with vomiting.
In case of gastric outlet obstruction with multiple episodes of vomiting, there will be hypokalemia, hyponatremia, hypochloremia, resulting in metabolic alkalosis.
What is paradoxical aciduria?
Sir, due to loss of HCl and hypochlorhydria and creation of alkaline medium, bicarbonate is lost by the kidneys. While bicarbonate is being lost, sodium is lost along with it. And because there is depletion of sodium in the body, the aldosterone mechanism gets activated. This will result in increased absorption of sodium. So instead of sodium, potassium and hydrogen ions will be pumped out in the urine with bicarbonate ions. So this hydrogen ion going in the urine will result in paradoxical aciduria.
Why it is called paradoxical?
So because the body has metabolic alkalosis, so there is no acid in the body to excrete, like acid, but because of the paradoxicity, the hydrogen ions are being excreted, so it is called paradoxical.
So urine is acidic, body is alkaline.
Yes.
Right?
Yes.
Now come to investigation for diagnosis.
In my case, investigation of diagnosis, as I said, first I will go with all the routine blood investigations. After that, I'll proceed with upper GI endoscopy to see the cause of the obstruction. If there is an ulcer or a growth, in the same setting, a biopsy will be taken. After this, I'll also go with CECT, abdomen and pelvis. If on upper GI
Endoscopy.
Yeah.
You entered into the stomach. What will you find in gastric outlet obstruction?
I will find a distended stomach with loss of rugosities and few...
Distended stomach.
Yes.
How can you find in endoscopy stomach is distended?
So when we put the endoscope, we can see the roomy stomach, like
Achha. Next,
taking the scope from top to bottom.
top to bottom.
Loss of rugosities will be there, and because
Loss
of
of
the
rugosity.
yes,
Why it will be lost?
so because of the distensibility, stretching of the stomach, the rugosities might be lost.
Achha.
Sorry, sir. Infiltration as well.
Next, what other things you will see in scopy?
So then in scopy, I will see if there is a suspected ulcer or a growth. If there is an ulcer, I will see the site, size and location of the growth and take the biopsy in the same setting.
Where from you will take the biopsy?
So from the same ulcer, I will take
Ulcer. Do you expect an
or a
ulcer?
mass.
There is a mass. True. Where from the mass? Mass is a 360-degree structure. Where from you will take the biopsy?
Sir, I will take 10 biopsies from all the quadrants, different quadrants of the mass.
15 quadrants.
All the quadrants, I will take total 10 biopsies from different quadrants of the mass.
Next, what else you will see in endoscopy? Should you enter into the duodenum?
Sir, Now there is a gastric outlet obstruction. Through the scopy, I can
How
try
you can-
negotiating the
How
obstruction.
can you know there is obstruction, outlet obstruction?
So if my scope is not going beyond the antrum in the duodenum, then I can know that there is an obstruction.
Right, you send it for biopsy.
Yes.
Sorry, biopsy chunk of tissue, send it for histopathological study. What do you expect to come out in the report?
Sir, in this case, I expect it to be adenocarcinoma of the stomach.
Adenocarcinoma of the stomach and obstructing the gastric antrum or the outlet.
Yes.
Right? What is your plan of management? Before that, what other investigation you want to do?
Sir, I have already done the basic blood investigations. I'll
Right.
also do a CCT abdomen and pelvis and CCT chest.
Uh-huh. Why
I-
you are interested for CCT abdomen?
Sir, in CCT abdomen, I will see where my mass is, what is the size of the mass, if there is any surrounding infiltration of the mass, any nodal involvement. I can also check for any liver metastasis or ascites.
Any role of endo ultrasound?
Yes, sir, endo ultrasound, the role is there. It is usually in early gastric carcinoma. Through endo ultrasound, I can see the mass and the layers of the stomach that it is invading.
Early gastric carcinoma, role of endo ultrasound. What will you find in endo ultrasound to stamp it as early carcinoma?
Sir, in early gastric carcinoma and endo ultrasound, I will find a small lesion which is well differentiated, piercing maybe up to the submucosa, mucosa and submucosa, not beyond that, sir. That will be early gastric carcinoma.
Early gastric carcinoma. That's-
Early gastric carcinoma is the carcinoma infiltrating the mucosa and submucosa and not beyond that, irrespective of the nodal status.
So that is diagnosed by endo ultrasound.
Yes.
It is such a huge lump. Do you prefer to go for endo ultrasonography?
No, sir, not for, because I've already gone for upper GI endoscopy and biopsy and it is a huge lump. Endo ultrasound will be used only later on if in case palliation is needed.
Your lump is extending from the outlet to the left hypochondrium.
Yes.
What is your plan of management?
Sir, I will first proceed with CECT and according to the report, if there is a locally advanced like it looks in my case, if that is the case, then in a locally advanced disease, I would first start with neoadjuvant chemotherapy, downstage the tumor and then plan for a curative resection, sir.
Carcinoma.
Yes.
What is the regimen for neoadjuvant chemotherapy in carcinoma stomach?
Sir, in carcinoma stomach, the current regimen is a FLOT4 regimen which consists of 5-fluorouracil, leucovorin, oxaliplatin and dox.
You do not say, we do not know.
Sir, I know, sir. 1 second, sir.
Okay. How long?
So this is given in 8 cycles, sir. So according to the neoadjuvant, it is a operative chemotherapy. So I will give 4 cycles before the surgery
Yes.
in a span of 3 weeks and then check if it is working, then plan for my surgery and then again complete the entire remaining 4 cycles as adjuvant.
So what is the surgery you plan? Come to the point.
Sir, if I see
There is no liver metastasis,
regression,
there is no ascites, nothing. Only confined to stomach and came out to be adenocarcinoma and you have finished 4 cycles of neoadjuvant. Next.
Sir, if the tumor is downgraded and shrinked in size, then I can plan for a distal radical gastrectomy with D2 lymphadenectomy followed by reconstruction.
Thank you.
Thank you.